And we're rolling.
Okay, let's get into it. We won't waste any time dilly-dallying. We'll just go straight into the content. So as I've already said, we're going to be covering endo and heme. But if along the way you have any questions about the rest of the topics we've covered throughout this year, or any of the topics we haven't covered, or anything that you found in your exams to be quite confusing when you're practicing, please do let us know, and we'd be happy to help you. Given this is our last session for the year, it's probably the last time we'll see you before you jump into the void of exams and we never see you again. So hopefully you guys get some time, or if you have any questions, please feel free to let us know. We'll get started. So we'll start with question one. I'll do my age-old tradition of trying to summarize and read through this so that we can get it done quickly. We've got a 35-year-old female who presents to the ED with a 3-month history of worsening weakness, fatigue, hypotension, and hyperpigmentation of the skin, particularly over some sun-exposed areas. She also has been experiencing abdo pain, nausea, and weight loss, and she has a medical history of autoimmune thyroiditis. So which of the following do you think is least likely to be seen when you do further diagnostics? Bearing in mind, what do you think this patient has? So once again, whenever you're ready, please feel free to chuck your answers in the chat. At this stage, if you just want to send it to me privately so as to give others a chance, that would be great. All right. Yeah, fantastic. So I've got already quite a few responses. The answer here is definitely A, it's hypernatremia. One thing to keep in mind is just be on the lookout for these negative questions where they ask for least or like not as likely or whatever, like which of the following is false, because that can really trip up students if they don't read it properly. But this is absolutely right. So we're dealing with a patient here who has Addison's disease or adrenal insufficiency. And you can tell because of several things. One is the hypotension. Then we've got the hyperpigmentation of the skin. And then you've got those like abdominal signs as well. Plus the fact that they have a history of autoimmune conditions. Addison's disease or adrenal insufficiency classically in developed countries is due to autoimmune processes. So all of it points towards adrenal insufficiency. And the classic electrolyte changes that you see, which is probably the most important thing to know in this topic, is that you will have hyponatremia, low sodium, but hyperkalemia. And generally, when one of those is increased, the other one is decreased, except for a few circumstances. You also do have metabolic acidosis. You usually will have a reduced morning cortisol because the adrenal glands aren't functioning as well. And you'll have a reflexive increase in the ACTH because of negative feedback. So well done. You won't have hypernatremia. The way I remember this is that people who have Addison's disease generally have salt cravings because they have a low amount of sodium. So if that helps you, that's great. So here's the next question. We've got a 28-year-old female who presents with 2 months of weight loss despite increased appetite, feeling hot, and palpitations. On exam, you note a non-tender, diffusely enlarged thyroid, fine tremor, and a non-pitting edema in the pretibial area. And the patient has difficulty with closing their eyelids completely since their eyes appear to be bulging outwards from the orbits. So which of the following blood tests is going to be most sensitive? Blood tests or scans or biopsy? Which of those is most sensitive for the diagnosis? Yeah, great. So this one, most people were really fast on the buzzer, so I don't think there's much to explain. Can someone just tell me what the diagnosis is here, most likely to be? Yeah, it's most likely to be Graves' disease. And you can already tell from the first 2 sentences that it's a case of hyperthyroidism. We know most commonly it's Graves, but the fact that the sentences that seal the deal are the non-pitting edema in the pretibial area. And you also have the exophthalmos, which is like 2 signs that are more likely to be seen in Graves than any other cause. And the most specific thing that you'll have is the TSH receptor antibodies, and these are the stimulatory antibodies. Just have a think about what the anti-TPO antibodies are for. I don't want to spoil any future questions. Radioactive iodine will just show uptake across the entire gland. And finally, I've just put in the red herring of the biopsy because that says thymus and not thyroid. So that wouldn't be very helpful in this case. So someone's asked, why wouldn't it be A? So A is definitely evidence that it's hyperthyroid because you have elevations in the thyroid hormones. But in terms of being more specific to Graves, the most specific test you can possibly order is going to be the TSH receptor antibodies, which is why you usually add them on to any patient that has hyperthyroid. I don't think you ever do biopsy of the gland, unless you're concerned that it's like a cancer or something like that. So hopefully that makes sense. Here's the
Real
next
quick,
question. This
if I can
one's,
just
oh yes,
interject
sorry.
real quick. I'm gonna post the derm lecture notes from Chris Chu into the Facebook, just for you guys to have a look at. So keep an eye on there, because apparently, yeah, you guys don't have access. Good stuff.
Thanks, James. We'll move on to the next question. So this one's a little bit of a tricky one, so I apologize. We've got a 60-year-old patient with type 2 diabetes. They're brought in by ambulance after being discovered by the neighbor on the floor of the apartment unconscious. Collateral history from her daughter reveals that she recently had a viral illness. On exam, the patient is dehydrated, has altered mental status, and nausea. You take a finger prick glucose because you know that it's pretty important in a trauma setting to have that done. And you have a plasma glucose that is quite high, 33, and there are also minimal ketones in the urine. So, which of the following options for management is most likely to be beneficial, or what's the priority? So, once again, remember these two-step questions, it's important to try and think about what do you think is the most likely cause of the presentation, and then work your way backwards and think about diagnosis or management. All right. So I've gotten mixed responses, a few that are on the right track and a few that are almost there. And I've purposely put in this question because it's something that stumped me during my own revision. So usually whenever you see a patient like this and you see that they have diabetes and that they've had an illness and that they're now presenting to the ED, automatically in your mind, you think this patient has DKA until proven otherwise. And therefore we need to start our whole providing saline, the most important thing being insulin infusions and that sort of thing. But remember that DKA is most common in which one? Type 1 or type 2 diabetes? Yeah, it's more common in type 1 diabetes. Very, very, very rare to get it in type 2. But what also helps us is the fact that there are minimal ketones in the urine, and you have just a very, very, very high plasma glucose, which is more likely to be seen in HHS than in DKA. And HHS is more common in type 2 diabetes. So they can both present in a very similar way. The main differentiating factor is presence of ketones, how high the glucose is, as well as what type of diabetes they have. So in this case, actually, you can still give insulin in HHS. If you look at the ETG guidelines, they do have a section which talks about insulin, but it's only really helpful or useful if they do have ketones. So in HHS, if you do have ketoacidosis, then insulin is super helpful. But otherwise, the mainstay of management of HHS is just going to be fluid resuscitation. That's really the only thing you need to do. So just to kind of clarify that point, just remember about the differences in presentation between DKA and HHS and what the overall mainstays of management look like. I think it's much more important that you have a framework for DKA, but just know that HHS is quite similar. It's just that insulin is not as important. Okay, well done. Here's the next question. I'll let Deepak take over.
Yep. So I'll follow in Janam's footsteps and quickly recap the question as well. So here we have a 25-year-old who has presented following a low impact accident, has some bruises and grazes, but otherwise she appears well. The main stem really starts when she reveals that she has had intermittent headaches for the past few months, and she has amenorrhea for 6 months and is failing to fall pregnant. And on examination, you notice poor peripheral vision bilaterally. What is the cause of this presentation? Yep, okay. I'm getting a couple of answers. I'll leave maybe a few more seconds. Nice, great work, guys. Okay, so this is if you don't quite follow what this question is pointing towards, don't stress too much. It's sort of like an R2 thing, but in this case, we've got someone with amenorrhea and a bitemporal hemianopia. So this is pointing towards the bitemporal hemianopia particularly is pointing towards a pituitary issue, a mass that's impacting in the optic chiasm. So it's sort of cutting out the sides of your vision. And the amenorrhea is explained by prolactinoma, because prolactin increase will inhibit your FSH and LH, and that's going to affect the cycles from occurring. So A is the correct answer. Good work.
Well done, everyone. Moving on to this question. So we've got a 53-year-old woman who develops polyuria, nocturia, and excessive thirst. On physical exam, there's no evidence of dehydration, but you've done a dipstick and it shows a low urine-specific gravity and nothing else. This is further confirmed by lab tests, which show really high serum but really low urine osmolality. You administer a dose of desmopressin, because that's what you do, and it results in a significant increase in the urine osmolality. So what do we think the diagnosis is here? So again, have a think about, this presentation of polyuria, nocturia, excessive thirst. It's almost making you want to think about something that you're very used to. But if you have a read further on, I want you to think about what else could be going on. Great, well done. I've got lots of answers already. The answer here is definitely diabetes insipidus. So just recalling that in patients with diabetes mellitus or diabetes insipidus, you have a similar sort of set of symptoms. You still have the polyuria, nocturia, thirst, but what differentiates them is dipstick findings, blood tests, and that sort of thing. So in this case, given the fact that you have a patient who only really has one thing, which is very, very dilute urine, and they have very, very concentrated serum, that tells us that they're probably peeing out much more water than a normal average person. And that's pretty much the definition of what diabetes insipidus is. But what helps us further that is that we've given desmopressin, which is the analog version of ADH, vasopressin. And that's corrected this change in osmolality. And so that kind of further tells us that it's probably most likely to be diabetes insipidus. Can someone please tell me, given the fact that this desmopressin has worked, there's like two different subtypes of diabetes insipidus. Which of those subtypes is most likely? It's just a bit of a bonus question. Yeah, it's most likely to be a central cause of diabetes insipidus. And the reason why is because if I'm giving the desmopressin and it's working, it means that the kidneys still are expressing the ADH receptors. And it's therefore not likely to be a nephrogenic cause, where in that case, you wouldn't have the receptors, desmopressin wouldn't work. And so in this case, you can just treat it with giving them artificial desmopressin to help. So well done. What's the difference between D and C? Yeah, so SIADH is it's kind of like almost the opposite. You just have way too much antidiuretic hormone being released. And one of the classic things you'll learn, or you have learned, is that it's part of a paraneoplastic syndrome. So that can be quite helpful. But regardless of that, ADH is antidiuretic hormone. So you would actually end up in a situation where you're not peeing out as much water. So your urine becomes more concentrated rather than less concentrated with diabetes insipidus. Hopefully that makes sense. And I think with that one, correct me if I'm wrong, James and Deepak, but with that one, I think you gave one of the diuretics. I think that's supposed to be helpful, like spironolactone or something, to block those receptors. I could be wrong. This is like I'm really reaching into the depths of my memory here.
Is this diabetes insipidus?
No, with SIADH.
Yeah.
Yeah.
I think it's spironolactone, but someone can correct me because this is like I haven't touched this topic in a while. But just know that they're pretty much polar opposites. Diabetes insipidus is not enough. Syndrome of inappropriate ADH secretion is too much ADH. Brilliant. All right. Next question. We've got a 33-year-old lady who has a 2-year history of irregular menstruation, hirsutism, and lethargy. She's otherwise quite healthy, although she does get admitted quite frequently to the hospital for acute asthma exacerbations. On exam, she has markedly high blood pressure, bruising on the arms and legs, and darkening of the skin around the palmar creases. So what is the most likely diagnosis in this case? Think about symptoms, signs, and risk factors potentially. Yeah, brilliant. Well done, everyone. So a lot of people get quite confused between the adrenal gland disorders, whether it's hyperfunctioning or hypofunctioning, particularly with Addison's, primary hyperaldosteronism, and Cushing's. A lot of that can get quite confusing, and you'll notice that the darkening of the skin aspect was seen here and also in Addison's disease. So that's not a very reliable way to figure out which one is happening. But the things that are quite specific to Cushing's more than the others is the menstrual changes, as well as the risk factor, or as well as the bruising and the high blood pressure. But the risk factor, which some of you have pointed out, is the fact that this is most likely to be an exogenous cause. She's been admitted several times for acute asthma, and you might expect in those admissions she was given quite a few steroids. And if you're pumping someone with high dose steroids, that can be a big risk factor to develop Cushing's. So all of those points towards the answer of C. And I'm glad not too many people got caught up in A or B, but if you did, that's okay. Just have a think about what each of these hormones does in the body, and how that will relate to the presentation that they have in the end. All right, moving on to the next question. Sorry, I know I'm also getting lots of questions in the chat. Some of the questions are quite long, so I may just in the interest of time have to wait till the end, so as not to hold up the rest of the session. But I'll definitely answer them closer to the end if that's okay. So I apologize for I'm not ignoring you. I definitely see those questions. All right. So a 65-year-old postmenopausal woman presents with a history of recurrent fractures following minimal trauma, including a hip fracture after a minor fall. On exam, there is loss of height and noticeable dorsal kyphosis. She's otherwise well, aside from a fear of needles, which causes her to have a vasovagal episode. So given the most likely diagnosis, what is the most appropriate next step to take? So do we perform a DEXA scan first? Do we just give a medication? And if so, which one? Or do we just stick with calcium and vitamin D and hope for the best? This one's a very tricky question because you have to think about a few things that are given in the STEM. But I can see most of you are actually on the right track, which is really reassuring. Yeah, and a few of you have actually gone above and beyond and given me an explanation, which is great. So it's always useful to be able to know how to justify your answers, because if you can, it just means you've made a stronger case. So absolutely right. In this question, we're just going to be going straight to giving medication. And the reason why is if you look at the ETG guidelines, you don't need to know them in too much detail at this stage for how to manage osteoporosis and minimal trauma fractures. Just know that if someone has lots and lots of risk factors for having fractures, then you don't have to bother with doing a DEXA scan. Because if you think about it, the DEXA scan is not going to change your management. You're still probably going to have to do something to protect this patient from further falls and further fractures. This patient is postmenopausal. They have already had evidence of a hip fracture. So that's quite a big type of fracture, but with minimal trauma. So you'd probably have to go straight to medication to protect them. Now, the question is which medication? We usually learn that bisphosphonates are the first one that you give, and that's actually the answer here. So the answer is D. But nowadays, people are moving towards denosumab more because it's a subcut injection. You don't have to give it as frequently, so it's better for compliance. But in this case, given the fact that she's not very happy with having needles, you'd probably want to do D first, then give denosumab instead. And no, you probably wouldn't want to just give them lifestyle advice, because if they do have a fall, God forbid again, it could be quite a bad fall and require more interventions and that sort of thing. At that age, not very good. Can someone answer why you think I put the upper GI endoscopy in E? So no one picked that, but why might that be? Why might I put that there? It's a bit of a weird question, but it relates to some of the medications that you guys were thinking of giving and potential complications you might get. Yeah, so bisphosphonates can cause esophagitis. You have to really counsel patients on how to take it to make sure that they don't have that risk. So you need to tell them to stand up for 30 minutes after taking the medication, usually on an empty stomach around 30 minutes before a big meal. So it's really, really important that you try and explain that. But that's the reason why it's there. You definitely don't need to do an endoscopy to confirm that they don't have it before starting alendronate. Well done. Okay, some lipid profiles. As part of a general well-man checkup, a 72-year-old gentleman has a few blood tests performed to assess his cardiovascular risk. He's assured to hear that most of his results are completely normal, apart from an abnormal lipid profile. And so just have a read of what that lipid profile looks like. And can anyone suggest to me what is the best medication or most specific medication for this lipid profile? Fantastic. Well done. So generally speaking, in these exams, I don't think they'd be mean enough not to give you reference values for these sorts of blood results. Like I only really started to consolidate in my mind what the normal blood results for cholesterol levels are this year. So if you're struggling to remember them, that's totally fine. I don't think they do that. But in this case, I've been helpful and just tried to write down which ones are high, which ones are low, which ones are normal. So in this case, we can see that the problematic thing is the high triglycerides. And while most people with abnormal lipid profiles, they go straight to first line statins. In this case, what's more likely to be helpful in lowering their triglycerides is a fibrate, which is why the answer here is C. And you don't want to just do dietary restriction, even though we love our lifestyle advice and lifestyle changes, because having really, really abnormal blood results, especially high total cholesterol, can be really bad at that age, given it's predisposing to lots of atherosclerotic diseases. So I'm glad no one has picked E or D. So the answer here is definitely going to be C. Now, in a similar vein, if you have a look at this patient's blood results, this is a 69-year-old gentleman presenting for the same thing. But in this case, they already have a history of high cholesterol, and they've been started on the maximum dose of simvastatin. But as you can see, it's not very well controlled. They still have high total cholesterol, very high LDLs. So in this case, what would be the next step? Again, once you have your answer, please feel free to pop it in the chat. Even if you think you're wrong, that's totally fine. It's always good to commit. And you'll learn something either way. Great, well done, everyone. So the answer here is a bit tricky because obviously you think first line statin, but they're already on the maximum dose. So you really can't increase that further. And the evidence shows that just switching from one statin to another is not really going to help because either way, it's the same mode of action that they have. So it's unlikely to give any additional benefit. What's better to do in this case is you already have a statin. So why not try something that has a different mode of action? And that's going to help to reduce that total cholesterol as quickly as possible. And again, if you look at the ETG guidelines, the second line drug that you give in this case is ezetimibe. So the answer here is going to be C. So that's why that's the case. I've got a few people asking, what is the maximum dose of statin? I actually don't remember what the maximum dose of statins are. Deepak and James, you guys are much smarter than me in this. I hope in this area.
I think the only thing smarter than you is ETG, so I'll pull it up.
Nah. Well, someone said 80 milligrams, so I don't know. Is that right? Like,
Oh, that sounds like a lot, but it could be.
yeah, that could be. I mean, if you're getting that from ETG,
Let me
that
just check
is
AMH real
that's
quick.
hands off. I can't really say anything about that. But if that's a guess, I'm not too sure. We'll have a look for you, and we'll type in the
Doesn't
chat
seem
what the maximum
unreasonable.
dose is.
Like,
Yeah. You by no means do you have to know that, by the way.
Yeah,
You don't
don't
have to
worry
know what
about
the
it.
maximum dose is. But it's cool if you want to know for your knowledge, if you see that on the boards.
let me
While James
see.
and Deepak are dutifully searching for that on ETG, I'll move on to the next
Oh,
question.
also, sorry. If you guys have any questions, if you guys chuck it into all chat, that'll help either me or James answer them while Jonam's presenting, if you guys want.
Yeah. 80
Absolutely.
milligrams according to AMH, by the way.
Oh, well done. Whoever sent that. It is 80
Although,
milligrams.
yeah, although it's different for combination therapy. So if you're chucking it in with a calcium channel blocker or amiodarone, then maximum 20 milligrams, with amlodipine 40 milligrams. And again, you do not need to know this. So chill, don't worry about it.
Yeah.
Way
Yeah.
down the track.
No worries. Thanks for looking that up, James. Okay, right, let's move on to the next question. This is not mine, I think. I think this is James. This might be you.
It's not mine, but I can run it.
Oh, we had a mysterious question appear.
Exactly.
James is brave enough to tackle
Where
it.
could it possibly have come from?
Have a go at this question.
Yeah. See what you think.
Oh, wait, this is my question. I think this is my question. Oh my God.
All
Oh
right.
man.
Jaden
I'm
can run
like,
this one.
I'm so out of it. Oh my God.
It,
Okay. 50 year. I was like, wait, because I always say gentleman, like that's my thing. I just always write that. So I was like, this is probably mine. Anyways, 50-year-old gentleman with type 2 diabetes and heart failure. They are managed with metformin, but haven't been able to quite get on top of their glycemic control. Kidney function is great, and they haven't had any adverse effects from the metformin, but they are worried, or he's worried about his weight on top of that. So I guess what medication is going to be great for his glycemic control, but also for his weight in light of his risk factors? Yeah, great. So while I was having a crisis and figuring out whether this was my question or not, I see a lot of you have already posted the answer. So it is actually C here. Well done. So usually in patients that have a past history of heart failure or really major like cardiovascular problems, you want to go straight to an SGLT2 inhibitor on top of the metformin that they're already on. So usually the way that you go is you do metformin. If that doesn't work, you try a different formulation of metformin, usually modified release or something that's going to work a bit more long term. If that doesn't work, then you add on an SGLT2 inhibitor. It's actually, if you look up if you look at the medications that have a mortality benefit in heart failure, we know about ACE inhibitors, beta blockers, spironolactone, but SGLT2 inhibitors are also part of that category. So it's really important that you know that. And someone has already mentioned this, but you also SGLT2 inhibitors are also really good for weight loss. So overall, like the best package deal for this patient would be an SGLT2 inhibitor. Some people have said E, you generally want to avoid glitazones in people with heart failure. I think it's contraindicated. And the rest are okay, but in terms of best option, it's going to be an SGLT2 inhibitor. All right. And someone just asked the step-up therapy for diabetes for us to walk you through it. It's actually that's probably like a whole lecture in and of itself on what the management of diabetes is and how it changes based on the specific patient. So unfortunately, most likely won't be able to go through the whole thing with you guys today. If you want to stay back behind and ask a few specific questions, we'd be happy to answer it. But your best bet is ETG. That's where I got most of my information. And there are a few summary tables out there with the different medications and things, including adverse effects and that sort of thing. So if you want me to pass that on to you, please do let me know, and I'm happy to do that. Fantastic. So this is not mine. I think this is Deepak now.
Yeah. Okay. So in this question, we've got a 63-year-old lady who has a chronic disease review. So she's got diabetes, hypertension, and gout, on medication for those, and currently smokes, and her blood pressure is just under the upper limit of what we consider hypertensive. Her HbA1c is 6.2, and in GP land, we do this thing called the CVD check, which is like an online calculator to calculate the risk of cardiovascular disease. And for her, it's sort of intermediate to high with a 15%. I think that's high, 15% risk in the next 5 years. So given that we know this, we want to do something to intervene on the cardiovascular risk. What is the most appropriate medication that we want to add? got a couple of answers rolling in. So just thinking about what are the key risk factors for diabetes that she has, and what can we do for that? All right, so I'll move on to the answer. In this instance, she in the numbers that we have for her, they aren't actually too bad in the sense of her blood pressure is under 140, although some guidelines do say 135 is preferred, but overall it's not something that we immediately look at and want to intervene on. Her HbA1c is under 7, which is not too bad. But in the instance of a high cardiovascular risk with someone with diabetes and hypertension, this is much in the same vein as the question before, where an SGLT2 inhibitor, dapagliflozin, would be the highest risk. Sorry for the background noise. And nifedipine is not the first thing that we want to add because her hypertension is not too bad. We don't know much about her lipids, so we wouldn't worry too much about a statin. And other than that, that leaves us mostly with the gliflozins, which is cardioprotective. You guys might have seen it on the wards being used more and more for heart failure as closer to first line, which is in keeping with the current evidence that we have for it. So it's a very good drug, and this is what we would use.
Yeah, well done everyone for having a shot at that question. It's definitely quite difficult, and you really do learn how to manage people with multiple chronic conditions when you get to your GP rotation. So don't worry if you didn't get to that. There's obviously a lot of things going on and you could do a lot of things, but it's about prioritizing and seeing what should be managed first in terms of immediate risk to the patient. So it's okay if you got it wrong. It's good that you had a shot. All right. This is actually based on a true story of Deepak last year. Trust me. You are late to a very important tutorial on anti-diabetic drugs. The tutor ushers you in and taps his wristwatch, saying that you are more than 15 minutes late. And according to university policy, this will go against your attendance. So seeing the distraught look on your face, your tutor strikes a deal. He points to a table he has made on the whiteboard, which pairs up anti-diabetic medications with their adverse effects. One of the pairings is incorrect, and he asks you to identify it. If you get it right, he will mark you present. And Deepak actually got this one right, so I'm expecting all of you guys to get it right as well. Which pairing below is incorrect? I couldn't figure out how to make this a question that was actually based on a STEM, so I ended up going with this.
Did this actually happen though?
Did this happen?
Deepak...
Wait, I don't know about this one.
It happened in my dreams because like Deepak is just goated with all this stuff, I swear. Diabetes.
Janum is so correct that he's still revising even when he's asleep.
I have no doubt Deepak would get this right if he was in third year. Let's see how everyone else goes. If I could say so myself, like these pairings that I have there, most of those these options contain most of the major adverse effects that you need to know about. So if you know this at a minimum, that's quite good. But it's also good to read up on some of the other adverse effects of anti-diabetics. And I can see a lot of answers already coming in, so that's great. The answer here is actually B. So metformin is great. Well, it's first line for type 2 diabetes, but it's great because it doesn't actually cause hyper or hypoglycemia. The things that we're worried about with metformin are what? What is bad about metformin that we need to be careful about? Yeah, we're worried about lactic acidosis. And so we just want to make sure that they don't have any renal problems to begin with. And there's guidelines around how bad renal function has to be before you say, okay, metformin is not the best idea, but it has to be pretty bad. So metformin is great for that sort of stuff. Sulfonylureas do cause weight gains. That's like your gliclazide and that sort of thing. SGLT2 inhibitors, we talked about how fantastic they are in heart failure and diabetes, but because they're impacting on, or they're causing you to pee out more water and sugar, essentially, you have an increased risk of UTIs, thrush, and that sort of thing. GLP-1 analogs, I didn't know this until today, but apparently they also can cause pancreatitis. So if you were caught up in that one, just know that that's a thing. Same with the DPP4 inhibitors. And finally, the TZD is the one that no one uses and no one knows how to pronounce, including myself. They are contraindicated in heart failure because they can also cause heart failure. Plus, I think bladder cancer. So just be mindful of that with the TZDs.
And yeah,
All right.
somebody, if I can chime in
Yeah,
real
no,
quick
go for it.
without taking up too much time. Somebody asked me, when would you add a sulfonylurea? In the year of our Lord 2023, not very often at all, honestly. Like I remember last year is not that long ago, really, but I remember talking to an endo guy at the Alfred for a shoot, something like this, potentially the same guy, and he literally said, like the PBS wants you to put them on a sulfonylurea before you trial, GLP-1 receptor agonist or a SGLT2. But basically, any endocrinologist would just think of one of the many contraindications for sulfonylureas. Also, the patient's very concerned about such and such, and use that to get through. So like even it hasn't for a while. We've been trying to avoid them because there is this big risk of hypos. They're not great drugs, and we just have better options. So have we talked about what the GLP-1 analogs actually are?
As in motive, I haven't talked about
As in like the
anything, so
drug, like
feel
which
free to.
drugs fall under that category?
Oh, I haven't talked about it. You can go
Yeah,
for it.
I was just gonna say real quick. So like your GLP-1 receptor agonists, those are the big new fancy like blockbuster weight loss drugs like Ozempic, aka semaglutide and all that. So that's those guys, and then you guys probably already know the SGLT2s are your gliflozins. Yeah.
Yeah,
So
anti-diabetic
the
drugs.
another term that you might hear potentially for GLP-1 receptor agonists is incretin mimetics. Um, Same thing. So they've been around for a while, but the really effective ones have come up more recently.
Yeah, absolutely. Look, anti-diabetic drugs was the bane of my existence back in third year, and it still is this year. But I'm slowly getting better, and I hope that by the end of by graduation time, I'm somewhat safe in prescribing them. That's the dream. So just know that it's very difficult. But if you do have like mnemonics and things to help you remember, like for gliflozin, I remember like flowing, so it's like urine. If you have a similar thing for most of the other ones, that can be quite helpful just to wrap your head around it. Okay.
All right, so I have a curveball as per usual. So don't worry too much if you guys don't get this, but I think it demonstrates core principles pretty well. So we've got a 16-year-old male from Africa who just arrived in Melbourne 4 hours ago, with severe left upper quadrant pain developing during the flight. And on examination, he's tender in that region, with blood tests revealing severe normocytic anemia with a high reticulocyte count. And ultrasound shows a heterogeneous spleen. What could be the most likely diagnosis here? Nice. Okay, I'm getting a lot of correct answers, which is very reassuring. I've taken this from PassMed, so perhaps there's some pattern recognition there, but I think, yeah, okay, I'll move on to the explanation. So essentially, what is happening here is this person has sickle cell disease, and this is an example of an acute crisis in it, or sickle cell crisis. So examples of sickle cell crisis are essentially, one is vasoocclusion, where your sickled cells clump up and basically occlude blood vessels, causing ischemia. You can also get hemolytic crises, where you get an accelerated destruction of the sickled red blood cells. Or you can get an aplastic crisis, where your cells aren't just being produced. So in that case, your reticulocyte will be low. In this case, your hemoglobin is low with a high reticulocyte count, with acute abdominal pain, which is very indicative of an ischemic event. And this is reflective by a heterogeneous spleen. So in a heterogeneous spleen, you have areas of infarct, which is sort of what that's pointing to. It's very non-specific, but that's the clue that we have here. And another differential would be a splenic sequestration crisis, where you have rapid pooling of blood in the spleen, but that wouldn't cause a that would cause more a hypertensive shock and stuff like that. But in this case, this is what we have to work with. The sort of significance of the flight as well, as someone very smartly pointed out, is the flight is pointing towards possible hypoxia, which led to the sickling of the cells in the first place, which sort of precipitated this whole event. So this is a very complex question with a lot of moving parts. So don't worry too much if you didn't get it. And it's not super duper R1, but I thought it was kind of cool and wanted to share it more personally. But anyway, good job, guys.
Big brain for thinking of that. I didn't know that the flight thing was related, so that's pretty awesome. I thought it was like a red flag for pulmonary embolism, but that's pretty cool. Just out of interest, last year when I was in the hospital on gen surg, there was actually a patient who had sickle cell, and then they had an autosplenectomy, which means that literally they got a occlusion of the splenic artery so bad that their spleen literally just died inside. So it can get pretty bad essentially, and this question kind of highlights that it could happen. So well done. I think this is you again, Deepak.
Yep. So in this instance, the question is essentially asking for a 33-year-old with a BMI of 45 who's tried things like lifestyle modifications for obesity. And they're basically asking you, what is the gold standard method or solution to weight loss that is long-term, that persists for more than just a few months? Excellent. I'm seeing some good answers coming in. Yes, gold standard. Nice. Very good. Okay, great work, guys. So yes, you guys are absolutely right. Bariatric surgery is the gold standard. With regards to bariatric surgery, you're not required to know too much in depth, but roughly the different types of surgeries, knowing the names of them and knowing some side effects or contraindications would be good in general. So for example, a sleeve gastrectomy will cause reflux because you're basically shortening this size of the stomach, and then the squeezing of it causes reflux, something like that. And a Roux-en-Y bypass can cause, since it bypasses the whole stomach, it can cause things like B12 deficiency. But yes, bariatric surgery is the most effective therapy for weight loss, both short-term and long-term.
Yeah, well done, everyone. Plus the fact that this patient is like BMI is 45, which is already quite high. You want to make sure that you're getting on top of their weight as quickly as possible because of the risks involved. And we always like to start conservative and work our way up, but sometimes you have to go straight to what seems like the most drastic thing for the sake of the patient. Okay, so in this case, we've got a 47-year-old construction worker that presents to your clinic with chronic lower back pain that has been troubling him for the past year. He's been tired, he's got some constipation, mild fever, and some lower tummy pain. His lab workup is shown below. Probably should have just highlighted the ones that are interesting, but just have a quick read over these pathology results, figure out what's wrong, and if you can put it all together, what do you think the most likely diagnosis is? This is a really important one just to know what sort of symptoms Monash can give you, because it's a cluster of things. I'll give you a few more seconds because it's a bit of a tricky one. I can see some answers coming through though. That's great. Yeah, brilliant. So everyone is basically correct. So the answer here is multiple myeloma, D. Now the reason why we're picking multiple myeloma and not some of the other options is because if you think about the four sort of cardinal symptoms or signs that you can get in multiple myeloma, which is CRAB, you get the hypercalcemia, renal problems, anemia, and bone problems. You can see a lot of that coming through in this patient. So you've got the chronic lower back pain. That's already a big red flag for cancer, whether that's like a metastatic cancer or whether that's a blood cancer. But then you've also got these additional things like the evidence of hypercalcemia on the blood tests. You also get that from, the stones, bones, groans, abdominal moans. So they've got constipation, abdominal pain. And then you've also got evidence of anemia with the low hemoglobin. And then finally, urea and creatinine. You can see the creatinine is a bit high. Urea is still in the normal range. So maybe not like full-blown renal problems, but definitely there's an element of renal issues there. You don't have to have all four for you to suspect multiple myeloma. But given that you have at least three or three and a half of those, it's most likely be multiple myeloma unless proven otherwise. So for those of you who picked B, hyperparathyroidism, it's very good thinking. You obviously had the calcium aspect in the back of your mind. But just to remember those additional symptoms, if you see them, then you're more likely to think multiple myeloma. Okay. This is going back to something that Deepak just talked about right now, but hopefully it's still fresh in your mind. So you got a 60-year-old patient who presents with fatigue, weakness, and pale skin. He noted that his tongue often feels very sore and he sometimes gets pins and needles. A full blood examination shows macrocytic anemia. So based on this, the clinician is pretty confident that the cause of their presentation is because of some sort of deficiency in a nutrient. So which of the following is least likely to cause a deficiency in the suspected nutrient? I'll give you a few seconds. Okay. So first of all, can someone tell me what nutrient is this person deficient in, most likely? Yeah, great. So the first step is figuring out what nutrient it is. And we know it's B12 because they've got the pins and needles. Well, first of all, macrocytic anemia. So we're thinking usually folate or B12. What puts us more towards B12 is the neurological sign. So we've got pins and needles. And they've also got this glossitis, which is the tongue feeling very sore or painful. So all of that points us towards B12, which is why the clinician was apparently so confident. But then the question is, what are some of the risk factors? So Crohn's disease, yes, because it affects the terminal ileum. That's where most of the B12 gets absorbed. So that's tick. Autoimmune atrophic gastritis. Does anyone know what the other name of that is? Yeah, pernicious anemia. So that's one of the autoimmune causes for why you can get B12 deficiency. You attack the parietal cells and that sort of thing. Proton pump inhibitors is very similar as well because you have reduced, that's again attacking the parietal cells, reduced acid secretion and therefore reduced B12 absorption. PPIs cause a range of deficiencies, including magnesium, something I learned this year. So just to keep that in the back of your mind, that PPIs are not as, I guess, safe as we think they are. Like they can still cause nutrient deficiencies. And strict vegan diet, because where do you get B12 from? What's like some of the common sources? Yeah, things like fish, right? So like B12, you can get it's mainly from meats. Whereas folate you mainly get from leafy green vegetables. So a strict vegan diet maybe not as conducive to B12. And methotrexate is like based on the way that methotrexate works, it attacks folate. So you're more likely to get a folate deficiency if you're on this medication. Same with medications like trimethoprim, have a very similar way that they work. So that's why E is the least likely to cause the deficiency. All right, well done. I'll try and go through this question as quickly as possible. We just got a 25-year-old patient who presents to the ED with fatigue, jaundice, and dark urine. He reports having eaten a delicious bean dish at a Middle Eastern restaurant. Physical exam reveals pallor and icteric sclera. Labs tests show hemolytic anemia, and you've got a blood film here. So just have a think about what that blood film shows and what this patient has. And bonus question, can you think about what probably led to this specific presentation? What was the inciting agent, if you will? Yeah, great. So I won't spend too much time on this. So what this film shows essentially bite cells. You've got the Heinz bodies on the top left. That's like the little inclusions, and then essentially macrophage comes over and eats that Heinz body out, and then you get the bite cell. That's how I remember it. I don't know if that's actually true, but you get something that looks like that. You get the bite cells, and that's very, very classic for G6PD deficiency. And again, another classic thing is when you eat fava beans. which is what I'm trying to get at with the delicious bean dish. That can be one of the things that leads you to having an acute attack. So you don't always have bite cells, but sometimes when you have like an inciting event, that can potentially happen. Another really good thing to keep in the back of your mind, aside from fava beans, is a lot of these sulfur drugs, like TMP, SMX, the antibiotics. If you give some of those sulfur drugs, they can also lead to an acute attack of G6PD. So well done. I think this is James.
It is in fact me. Yep. So we have a bit of an interesting long-running history for this guy. And looking at the options, you can already see what I'm pointing you towards. We have some very classic symptoms for lymphoma. The question is, what type of lymphoma does this man have? So have a look. Okay, I'm getting a couple different answers. Keep them coming. I'll give you guys a couple more minutes and then second, and then I'll say what we're thinking. A lot of people seem to be not quite sure, which is good. This isn't even path. This is like this is just classic history. I haven't included any pathology findings at all. Although, yeah, the path questions for make sure you revise lymphoma path though, because those are brutal actually. I think I don't think I got any of them right. Yeah, I got them right at the time because I knew it at the time. But if you ask me now, I would not know what was what. Cool. Okay, so got a big mix of answers. Nobody went for C or E. Very sad. But we have some for A, we have some for B, we have some for D. So let's look at our history here. So we have a whole bunch of B symptoms here. So we have unintentional weight loss, and he's waking up at night. He's clammy, so that's night sweats, and he's hot. So he has a fever. Okay, he's got basically a classic triad of B symptoms. Now, as a general rule, or in general, we expect to see B symptoms more likely in Hodgkin's versus non-Hodgkin's lymphoma. And the rash that we have got here, which is associated with pruritus, is also a Hodgkin's sign. So both of them are going to point us towards Hodgkin's lymphoma. Now, your follicular and your DL B cell lymphoma are both types of non-Hodgkin's lymphoma. The other thing that's pointing us towards Hodgkin's is that it's younger. The patient is younger. Usually, you'd expect to see it in a younger female more than a younger male, but you can still get it in a younger male. And of the Hodgkin's types, nodular sclerosing, A, is by far the most common. It's about 70% of Hodgkin's lymphoma. So that is the most likely diagnosis in this case, nodular sclerosing lymphoma. It's not to say that you can't get B symptoms in non-Hodgkin's, but they're much more typical of Hodgkin's lymphoma. Cool. And with Hodgkin's, bonus points if you can tell me whether you're more likely to get sort of distant spread in Hodgkin's versus non-Hodgkin's. Which one are we expecting to be more localized? Which one are we expecting to be more spread out? Somebody said localized in Hodgkin's. Yeah, that's correct. So Hodgkin's is the, quote unquote better lymphoma to get because it's a bit less aggressive, it's more localized, and it's therefore easier for us to treat and to have a better prognosis. Of course, it's still cancer, but that's a differentiating feature again. Good stuff.
Great. Well done, everyone. You are all obviously better than me. I wouldn't have gotten this right. So well done, all of you. Next question. Something that hopefully a bit easier on my brain. A 12-year-old Mediterranean boy presents with chronic fatigue On exam, he has severe pallor and evidence of moderate hepatosplenomegaly, and the lab confirms that he has a microcytic anemia. Your treating clinician suspects an intrinsic genetic problem with the red blood cells, particularly due to a strong family history. Given what we think is going on, which of the following findings is most consistent? And again, if not all of these options make sense, or if you've not heard of a few of these, that's okay. I just encourage you to read up on them because they're essentially buzzwords for different things. And if you're stuck and you're not really sure what the answer is, if you just want to type in what you think this patient has as like the first step, that's okay as well. Yeah, fantastic. So the patient here has what most people have suggested. They have a beta thalassemia, and we get that from a few things. Once, like first of all, the demographic information that's given. Usually, if you have a patient that has any thalassemia, they'll be very specific with where this patient is coming from, because of the preponderance towards specific demographics. So Mediterranean makes us think it's more beta than alpha thalassemia, and because both of them can still cause a microcytic anemia and present very similarly. So if we're thinking that it's a beta thalassemia, the main thing you need to think about in terms of investigations is that you have to order an electrophoresis, plasma electrophoresis. And the main finding you get on there is you have elevation in a specific type of hemoglobin, which is HbA2. That's why the answer here is going to be C. The other ones, just to give you some closure, the sickle-shaped red cell, that's sickle cell anemia. We talked about that a bit ago. Pepper pot skull, does anyone know what that is referring to? What sort of condition you see that in more frequently? So when you order an X-ray of the skull, yes. So in hyperparathyroidism, you can get this what's called the pepper pot skull, but usually you don't bother with doing a cranial X-ray in those cases. It's just an interesting finding. And positive Coombs test is just telling us that this is some sort of autoimmune process, which is not the case here. And you wouldn't have low serum ferritin. Usually it's normal in beta thalassemia. Well done. Okay, so a bit more on blood stuff. As you can see, we're transitioning towards heme. So you've got a 6-year-old boy presents to the clinic after being treated for an episode of prolonged bleeding after a dental extraction. He has come in several times before for uncontrolled bleeds, so he's got a big history. His mom recalls both her father and father-in-law having a similar series of episodes, but not herself, her husband, or anyone else in the family. So a bit of a family history involved. You decide to order coag studies, which shows everything has been normal except for a prolonged APTT. So if you can think back to your coagulation cascades and what factors may be involved in a specific type of prolongation, and that can be very helpful. All right. I'll give you a few more seconds. All right, let's get into the answer here. So we've got a few mixed responses, but they're both responses that I knew were going to come up because they're quite similar in terms of the blood test results that you get. So I'm really happy that this point of confusion is here now. So essentially, you've got a patient who has a family history and a personal history of having excessive bleeding with just really minor things, right? So we're thinking this is going to be some sort of coagulation/clotting problem. And the question is, what is it? Well, you can look at, first of all, the family history, and you realize that only males were affected. You got the father and the father-in-law, but the mum's father and the mum's father-in-law. So you've got 2 males already, but it seems to have skipped her husband, right? So it's gone from the top, skipped the husband, and now it's appearing back in the boy. So we're thinking, yes, it's probably X-linked because it's male preponderance. But the fact that it skipped a generation makes us more likely to think it might be X-linked recessive. So just to keep that in the back of your mind, if that wasn't quite clear. But then if we go to the actual blood results, you'll see that the only thing that's elevated is APTT. And APTT is an indicator of the intrinsic pathway of the coagulation cascade. A way that I like to remember this is I just think of the mnemonic ICE ATP. So if you actually, I might not explain it because it's very difficult to explain without a diagram. Just I'll write it in the chat so it helps you to figure out what's happening. But essentially, that mnemonic tells me that APTT is good with the intrinsic pathway. And I know some of the major factors involved in the intrinsic pathway. One of them is 8. So that's the one of the clinically significant ones. So you might be thinking, okay, von Willebrand or hemophilia A, probably not the other ones. So hemophilia A specifically is factor 8. Von Willebrand affects the von Willebrand factor, which also has a role with factor 8. The main thing that differentiates them is the family history. So while von Willebrand disease is the most common type of blood disorder, clotting disorder, hemophilia A is more likely given the fact that we have this X-linked recessive pattern of inheritance. Hopefully that makes sense to everyone. But again, I got a mix of A and B, which is really reassuring because it tells me you guys really know which part of the clotting pathway is being affected in this case. Okay. And I will certainly explain, I've got a few questions. I will certainly explain what that mnemonic I was talking about means, maybe in a diagram that I'll send in the Facebook chat later on, or the Facebook group later on. Okay, we've got a 70-year-old patient with a history of DVT and chronic kidney disease. Presents to the ED with a sudden onset dyspnea, pleuritic chest pain, tachycardia. The patient has been bedridden for several days after undergoing an extensive hip replacement and has since complained of calf tenderness. So first of all, what do you think this patient has? And secondly, what is the most appropriate next step given how urgent we think this patient's condition is? So again, I want you to think back to that osteoporosis one. We know that it's obviously gold standard to try and get the DEXA scan done and then initiate management. But in a similar way, can you think of the urgency for which this patient is presenting and what would be the best to do first? Fantastic. Well done. So I can see a lot of you have already looked into this patient's background and their comorbidities and thought ahead to what kind of imaging or medications we can give. But it's really good that you've identified that just based on the stem alone, this patient has all of the major signs and risk factors of a pulmonary embolism. And you can sit down and more formally do a Wells score, which is essentially the way that we stratify whether patients need treatment urgently or whether they can have imaging first and then treatment potentially. You also got the PERC score, but that's used more to rule out a PE in a patient that is very unlikely to have a PE to begin with. So just know those scores and what they mean. But in this case, you don't really need the score because everything is pointing towards a PE, most likely, including calf tenderness, the hip replacement. So you've got bedridden, that sort of thing. So it's actually more wise to have started the empirical dose of an anticoagulant first before you say, okay, I'm going to do imaging and then wait to give medications because this patient could die in front of you within a matter of minutes. So you want to start that dose first. And then, yes, you may consider doing imaging later on down the track just to see if you've cleared things up. So the answer here is actually B. Now, if we were thinking of doing imaging and this patient was more stable, a lot of you have already told me the answer to this, which is you'd probably want to do a VQ scan more than a CTPA, given their chronic kidney disease. And I know there's like more recent evidence to show that really the contrast used in CT scans is not really that bad for kidneys. But I guess for Monash land, just know that you want to try and avoid contrast. So you do a VQ scan. And I'd also encourage you to think about the types of anticoagulant medications you would give to someone who has kidney problems. So which ones would be safe and which ones wouldn't be safe as first-line management. But I won't delve into that too much just for time. It's just a good idea for you guys to have a read up on that. Okay, next question.
I think this is mine. So we've got a 43-year-old male presenting with lethargy. And the main thing that we have here are a bunch of investigations. Notably, this man is very hypertensive with 192 on 112. Blood test showing hypernatremia, hypokalemia, high bicarb, normal urea, and normal creatinine. What do you guys think? What is the most likely diagnosis? Nice. I'm getting a couple of good answers. So in this case, the clue really is the hypernatremia and hypokalemia. We briefly touched on that earlier in the session, I think in one of Janum's questions, but when we see that two things together, we can think back to the function of aldosterone and what aldosterone does in the body. Aldosterone serves to retain sodium, and by retaining sodium, it pulls water in and it excretes potassium, leading to a low potassium and high sodium with a hypertensive state because you're sort of like fluid overloading yourself. And that is going to be the answer. So D, otherwise known as Conn's syndrome, is essentially what's happening here. The reason for the raised bicarb is what happens is when you have low potassium in your body, in your bloodstream, your body is going to compensate by bringing potassium from the intracellularly into the blood vessels. So it's going to pull potassium out of the cells, but to maintain the sort of the electron balance in terms of positives and negatives, now we want more positives inside the cells intracellularly. So we end up exchanging the intravascular hydrogen ions with the intravascular potassium. So what happens is potassium moves from cell to blood and hydrogen moves from blood to cell. And to compensate for that change, you're going to need an increase in bicarb. Essentially, you're going to dissociate more H2CO3 into HCO3 minus and H plus to compensate for the drop in hydrogen ions to maintain the level of hydrogen. So you end up with sort of a reflex bicarbonate increase. I hope that sort of makes sense. You wouldn't expect pheochromocytoma, you would see more symptoms, it would be more episodic. Renal artery stenosis, in a question, they would typically talk about bruits, renal bruits, and the other two are generally less likely for this picture. So yeah, good work.
Is this, James, is this your question?
This is my question. So have a look at this one and see what you think. So interpreting, I think we mentioned this already, but interpreting just test results is going to be a fairly big part of your exam too, if they kept the format the same as last year. So stuff like your iron studies is very high yield. Okay, got a few different answers coming through. Feel free to chime in. Okay, we have a few different things going on here. Interesting. Okay. Some for A, some for C, somebody for not an iron-related pathology, which is, could very well be. As in, you could have a normal iron study. They don't have to give you something pathological. But let's look at what we actually have here. So we have an iron of a low iron. We have a normal transferrin, but it's low bounds of normal. Same with the total iron binding capacity. It's also low bounds of normal. We have a normal transferrin saturation, and we have a slightly increased ferritin. So let's look at the history for some explanation of what's going on. So we have a 6-month history of fatigue, and we have recent upper respiratory tract infection. Now, can anyone tell me what the significance of the ERT is to the ferritin in particular? Somebody said ferritin is an acute phase reactant. Absolutely, yes. So ferritin, we expect to be up in the context of a inflammatory illness. So if we did a CRP, it's probably going to be elevated as well. So with that in mind, you're going to actually ignore that high ferritin because you don't know what the ferritin is normally. For all we know, the ferritin could be low normally. So we can go through and we can actually look at the actual iron itself. So you've got a low iron, we have low normal transferrin in TIBC. And given the history, so this is the key thing. So looking at the iron studies on their own, you could, maybe it's just a normal iron study. It's not unreasonable. The iron's pretty borderline. Everything else is, pretty explainable as just a variant of normal. But 6-month history of fatigue means that there's probably something going on. So certainly they don't have hemochromatosis, doesn't make any sense. Sickle cell anemia and thalassemia, I just put in there as distractors because they don't make any sense either. Anemia of chronic disease, I can sort of see where you're coming from, but we'd expect to see a decreased transferrin and total iron binding capacity. And here we actually have a low normal, and they also decrease in the context of an acute response. So if they've come down in an acute phase and they're still normal, that means that they were increased to start with. So the overall diagnosis is iron deficiency anemia with a recent/current ERT acute phase reaction.
Great, well done, everyone. We'll move on to the next question.
Sorry, somebody asked,
Oh, yeah.
can I explain about the transfer in TIBC? Sure. So transferrin and TIBC are both expected to be up potentially in iron deficiency anemia. Anemia chronic disease are expected to be down, and they decrease when you have an acute phase response. So if you have anemia chronic disease and then you get an infection, you expect to see quite a low transferrin and TIBC. If you get iron deficiency anemia and then you get a infection, then it could be low normal or it could be decreased. So we've got a low normal result here, which is not what's consistent with anemia of chronic disease plus infection, but it is consistent with IDA plus infection. Also the history. So just like always looking at the clinical context with this sort of stuff.
Great. Okay, moving on to the next question. We've got a 28-year-old man who presents with painless enlarged lymph nodes in the neck, night sweats, weight loss, and pruritus. We've seen this picture before. Exam reveals firm rubbery lymphadenopathy and a biopsy is taken. And the report is listed there. I won't read it out. Based on that, what do we think is the most likely diagnosis? All right, a few more seconds and then we'll discuss the answer. Yeah, fantastic. So look, I did say that I don't like path a huge amount, but there are a few things in path that are probably quite important to know. In this case, we've got obviously a patient who has a lot of these B symptoms that we discussed before. And we've got the rubbery lymphadenopathy. So that's quite, I guess that's putting us towards a lymphoma. So most of you got that down pat. With regards to the description, with the multi-lobed nuclei, does someone want to tell me what that is actually referring to in terms of the pathognomonic name for that type of cell, which I've been mean enough not to write in and of itself, but I've seen it referred to as multi-lobe nuclei instead. Yeah, so it's a Reed-Sternberg cell. And we know that that's very, very specific or pretty much pathognomonic for Hodgkin's lymphoma, which is why the answer here is D. So what I basically, this question is trying to tell you is, yes, know some of the pathognomonic names for things or the eponymous names for things, but also know how they might describe it in other terms that make it a bit less obvious. Another classic example is those Kimmel-Steele-Wilson nodules that you see in diabetic glomerular nephropathy. Sometimes they tend to describe it in different ways rather than just giving you the name. So it's quite helpful just to know because they can be a bit mean like I've been here. But it looks like most of you have noticed that it's essentially talking about Reed-Sternberg, and you've gone with D. So well done. Okay, now we've got a 50-year-old patient who presents with fatigue, night sweats, and splenomegaly. Complete blood count reveals a markedly elevated white blood cell count, 220,000, which I'm assuming is quite high, with 20% myeloblasts in the peripheral blood. And the differential count shows a bunch of different cells, including granulocyte precursors, neutrophils, and basophils. So given what you might think this patient has, what is the most likely translocation? And even if you're not sure, just think about what is like the most important translocation that I guess Monash would want you to be aware of in the context of blood cancer. Yeah, great. So it looks like the heme path knowledge that you guys have had from recent is still there, which is fantastic. So in this case, we think this patient most likely has chronic myeloid leukemia. You've got someone who fits the bill with regards to age, as well as the fact that the myeloblasts are the ones that are highest. There's no mention of lymphocytes or anything like that, or lymphoblasts. So we're thinking this is CML. And the specific translocation you have in that is T922. In other words, does anyone know what the name for that is based on a place in the world? Yeah, it's a Philadelphia chromosome. So if you see that, just know that that's CML, so T922. And again, I'm so sorry because I know I keep saying that I hate path, but we've got another question that is to do with path because I think this one is maybe still a little bit important for you guys to know. And it's a cruel reminder to the fact that questions like this can still come up. So we've got two patients who are admitted into the hemonc ward. Unfortunately, due to a similarity in their names, their path slips got mixed up. You have the blood films in your hands, and the pathologist has been helpful enough to label some of the interesting things with arrows because I couldn't remove the arrows myself. So what do we think these patients have from left to right? So take it one at a time and try and think about what those arrows are pointing to specifically. And again, if you're not really sure what the condition is, even if you know what the sign is, please feel free to write that in the chat because it's a really good first step to getting to the final answer. Great. Well done. Well done, everyone. So can someone just tell me what is the sign that we're looking at? What type of cell are we pointing to in the left image? What's that called? Yeah, so we've got smudge cells, which is like those really just like fragile cells that you get when you spread the blood across the film. That's quite specific. Well, not very specific, but it's somewhat seen more often in CLL. It's really like the only major thing you see in CLL is those smear cells or smudge cells. And a few people have rightly pointed out in the right image, you have these rods that you can see inside the cytoplasm, and those are the hour rods. They're actually not very common to see from what I've read online. They're quite rare, but when you do see it, it's quite specific for AML, acute myeloid leukemia. So we actually have two patients here, one with CLL and one with AML. And so just for basically that's like the only important thing you need to know for CLL, AML, and we just discussed CML as well. And ALL is the one that's more likely to be seen in kids, so that can be quite helpful. So just know a bit about the four of them, but for the purposes of your exams, they won't be this mean. This is just to make sure that you have an understanding of what some of the common pathology findings can be. So well done for all of you guys who got it. I think this is James again.
This is one of mine, correct? So have a go. What do you think we're gonna? Maybe I'm being a bit mean here, but it is something that is worth knowing because they can ask you questions about this. So the question is, we've had a PE. What are we going to do about it? Getting a few different answers. Okay. All right, I'm getting some for B, some for D, some for E. Let's have a look. Let's figure out what we're gonna do. So, I guess there's two questions here that I've given you by choosing these options, which is what drug are we going to give him, a DOAC or a heparin, a low molecular weight heparin, in fact, and for how long. So on the first question, low molecular weight heparin versus a DOAC, well, our last sentence here says that they're trying for a baby. So if someone is even on it, like it's a bit subjective how far you want to pull it, but you generally want to be careful in definitely anyone trying for a baby, anyone who reckons who it might be on the horizon, or they're open to the idea, or even who's like, if I get pregnant, I want to keep it, and they're not using contraception or they don't have long-term reliable contraception. And in some cases, even you'll see guidelines based off like women of reproductive age, basically. So there's a whole spectrum of how far you want to take it. But somebody who's like point blank telling you like I might get pregnant soon, absolutely you go for whatever's safe in pregnancy. Okay. So in this case, we're not giving her a DOAC, we're giving her a low molecular weight heparin because that's what we do for people who are in the middle of pregnancy. So the question is, how long are we going to put it on enoxaparin for? Indefinitely 6 weeks, 3 months. So the sort of central question here is whether this was a provoked PE or an unprovoked PE. Now we have an insult here, which is we have a knee reconstruction, we have surgery, probably sitting around, not mobilizing very much, and that's probably going to be a provocation for the PE. So we would not regard this as an unprovoked PE. We would say this is provoked by the surgery and the hospital stay in immobility, which means that we give her a regime of 3 months. So the answer is E. 6 weeks is the minimum. You probably wouldn't give her the minimum. And indefinitely is what you do if it's unprovoked. So if someone comes in, if Sarah's come in just from the community, she hasn't been on a plane, hasn't had any periods of immobility, nothing's going on, no comorbidities, and she just has a PE, then you say, oh shit, I guess you're on, in this case, you probably put her on a long-term enoxaparin, and then, eventually shift that to maybe a DOAC when she's like family complete or something. But the point is they're staying on an anticoagulant because the risk is too high.
Great, well done, everyone. Moving on, so 55-year-old patient who presents with diarrhea, flushing, and a hard, painless thyroid nodule that's been slowly growing in size. Given you have a high suspicion for malignancy, a fine needle biopsy is performed on the nodule, which shows polygonal cells with amyloid deposits in the stroma. And you've also got a high serum calcitonin. So hopefully that this is enough information based on your path knowledge to figure out what subtype of thyroid cancer we may be dealing with. So just have a think. Yeah, great. Well done. So the answer here is C. It's the medullary subtype. And there's a few things pointing towards that. First is the pathology findings in and of itself with the polygonal cells, amyloid deposits. That's very, I guess that's quite specific to medullary. And there's a few mnemonics going around there, like there's like the 4 M's of medullary, and there's the 4 P's of papillary, the 4 F's of follicular. It's really good, I guess, for your path exams when you had those to have those mnemonics in the back of your mind. But just for your final year exams, it's not that important to know every single detail, but just know the buzzwords. And things like calcitonin levels being elevated in the context of thyroid cancer, that's quite specific for medullary, even though papillary, I think, is the most common. Well done. Okay, back to some endo. So we got a 40-year-old female patient that presents with generalized bone pain, muscle weakness, and difficulty in walking. On exam, she has tenderness in the pelvis and lower back, and lab tests show low calcium and phosphate, but quite high parathyroid hormone. And you see some pseudo fractures and thinned cortical bone on X-ray. So based on that, what do we think is the most likely diagnosis? So it's really good idea to know your bone profile and sort of what blood tests are associated with what specific conditions. They all have very similar sounding names, which makes it quite annoying. But I can see that a lot of you have already identified what is most likely going on. So the answer here is D, it's osteomalacia. And you suspect that in any patient that has these lab results, so the low calcium and phosphate but the high PTH, because it's an intrinsic problem in the bone. And so you have a reactive increase in PTH, but low calcium phosphate. And especially with this picture of the bone pain and difficulty walking, remember that osteomalacia also has its counterpart in rickets, that's in children. And the most severe version of rickets, you have that waddling gait and the difficulty in walking. So it's quite similar in osteomalacia. If it gets pretty bad, you can have problems with walking. You also have the pseudofractures and things like that, which is also seen in osteomalacia. I think they're called like Milker fractures or looser zones and things like that. There's like a few buzzwords, but I've just put them in words instead to make it a bit easier. And just know what the bone profiles would look like for osteoporosis and osteoarthritis. Whether you would expect any changes in the bone profile or not is also quite important. Okay, I think this is Deepak. I could be wrong. Could be
Nope,
him.
this is one of mine. So have a go at this. This is actually quite high yield, because they do like asking you about different forms of thyroid stuff. Okie dokie. Interesting. All right. So, we have a couple different ideas here, which I'm very interested in. So, we have a hypothyroid picture. That's what's happening in the blood, as in the hormones that are in the blood. So something is screwing with our thyroid function. We also have a painful goiter. So I had a lot of people suggesting Hashimoto's disease. We would typically not expect to see an actual tender goiter in Hashimoto's. It should be a painless enlargement. We also have a bit of a risk factor there of a smoking history. So the fact that it is painful, and also especially the fact that we have a cervical lymphadenopathy, points us towards malignancy rather than autoimmune hypothyroidism. Okay. Now somebody suggested Decovains, which is a very smart differential, which is I intentionally left out of here because it would be another option. But the thing I wanted to point you guys to instead is a form of thyroid cancer. So the question is, which form of thyroid cancer is going to give us lymphadenopathy? And that dives into, there are 4 types of thyroid cancer you guys need to concern yourself with. And they all have different methods of metastatic spread in general. So the way that I tend to remember them is follicular cancer. You have far away mets because it spreads through the blood, so hematogenous spread. Papillary carcinoma, P for palpable, because you get palpable lymph nodes because it has how do you pronounce it? Lymphatic spread, Jesus. Which is going to be the answer here. Okay, so papillary carcinoma. I don't have a snappy way of remembering medullary anaplastic, like the types. But if you remember that anaplastic is the really crap one, like the one that you get and you're like, oh shit, this is terrible. Then you'll remember that it's local spread, because that's why it's so bad, because it's going to encroach onto all the structures in your neck, and it turns out that you actually need most of the things in your neck. And that's why we care so much about it. So remember, follicular, far away mets, hematogenous, your papillary, palpable lymph nodes, medullary, you actually don't typically get metastases, which is why it's not terrible, but you don't have great outcomes. And then anaplastic. Why is it? So I've got a couple questions. So why is it painful? To my understanding, you can get painful goiter with malignancy in general. I think as a result of just enlargement, pressure, invasion of tissue. Maybe I need to get fact check on that. I'm not sure. But people have, somebody else has very rightfully asked, would you see lymphadenopathy in Derquevains given recent viral prodrome? Yes, quite possibly. So that's why I didn't put Derquevains in here, because it is a pretty reasonable differential. I haven't given you a length for this history. So if I said this was a 6-month history, then that's going to tip you towards carcinoma. If I say that this is a 2-week, be a bit short for weight gain. But if it was a 2-week history and it was associated with a fever, then probably you're leaning towards Derquevains thyroiditis instead. Good stuff.
Great. We're on to the last question, everyone. So just one more to go. We've got a 34-year-old patient with a history of intermittent hypertension, episodic headaches, and excessive sweating. They also have palpitations and weight loss. During one of these episodes, the patient's blood pressure is very, very high, 190 on 110. And your exam is pretty unremarkable except for some fine tremors. So based on what you think this patient has, what is the most likely investigation, or best investigation, I should say? Yay, fantastic. Okay, great way to end. So essentially, we have a patient with the episodic symptoms that Deepak alluded to previously, and that's more likely to be a pheochromocytoma. That's just pumping out adrenaline, noradrenaline, that sort of thing, episodically, and leading to these symptoms that we have in this patient's stem. And the very, very, very high blood pressure also helps us to seal the deal. So in this case, I guess the gold standard would obviously be to get some imaging to see where these adrenaline and stuff is coming from. But the first sort of investigation that you tend to do is either serum or urine metanephrines, with urine being the easiest one to get. So that's why the answer here is C. Can someone tell me what the renin-angiotensin ratio is useful for? It's a condition we've talked about previously that also leads to high blood pressure. Yeah, with a primary hyperaldosteronism or Crohn's, which is actually an extremely common cause of what some people may have thought is idiopathic hypertension, is actually due to primary hyperaldosteronism. It's an area of great research. So that's just something to keep in the back of your mind. But in this case, given the intermittent episodic nature, we think it's pheochromocytoma, and hence why the answer is C. So that is the end of today's slide set and the end of our run for third year. I think that's all the questions that we have. So if you guys have any questions for us, please feel free to let us know now. It's been a pleasure to run these sessions for you every so often, and we hope that you found great value in coming to them, even if you felt like absolute crap leaving because you feel like, oh my God, I don't know much. Just know that it felt the same to us when we were writing the questions, because obviously it's a lot of information for you guys to have to remember for your exams. But you guys, as a cohort, the PS Platypus cohort, you guys did really, really well in the quizzes. So you should be really proud of yourselves. And on behalf of the whole team, and I'll let James and Deepak also reiterate, but on behalf of the team, best of luck for your exams. Go ahead and smash them because you guys deserve the highest of the highest marks.
Yeah, no, I won't take too long, but you guys have been amazing. Every week I come here on these Zooms and I look at the answers in chat. I'm like, you guys are getting the majority of these right. It's only really the tricky questions that I see you guys start to falter, and that's really good. That's a really solid foundation. And obviously, like, the whole point of these is to try and push you a little bit. And hopefully you've learned something from these sessions. Hopefully you found it useful. And yeah, no, best of luck. don't stress about it. Don't worry. It's all pass fail now. So don't feel like you need to be stressing about it. You need to be neglecting yourself in the lead up to exams. Take care of yourselves and do as best you can. All the best.
Yes, take care, guys. One thing that I think is useful to sort of think about is these exams are just exams, they'll come and go. But if we find a way to make studying fun for us, we can study forever. So let's try and have fun while we do this stuff, because we'll be doing it for a while. Oh my God, what was that?
All right.
Whoa, how did that happen?
All right.
Yo,
See you.
oh my God.
Like,